Hi, everyone. We'll give it a few more minutes to allow more people to show up. All right, let's get started. I'm Alex Jeffrey. I am pediatric neuro co-chief resident. It is my honor to introduce Dr. Basil Darras. He is the distinguished Joseph J. Volpe Professor of Neurology at Harvard Medical School. At Boston Children's Hospital, Dr. Darras is chief of the Division of Clinical Neurology and director of Boston Children's Neuromuscular and SMA programs, which includes one of the oldest and most active muscular dystrophy association clinics in the country. Dr. Darras is a pediatric neurologist with advanced training and certification in human genetics and neuromuscular medicine. His primary research focus is in the field of pediatric neuromuscular disorders. His specific research interests and major publications have focused on the molecular genetics, diagnostics, and therapeutics of Duchenne Becker muscular dystrophies and spinal muscular atrophy, SMA, and on defining the indications for new diagnostic methodologies in the evaluation of children with pediatric neuromuscular diseases. His clinical focus is in the care of children with neuromuscular conditions originating from inherited or acquired conditions of the motor unit. He is the principal investigator for the Boston Children's site of NIH's NeuroNext Clinical Research Network, for the Pediatric Neuromuscular Clinical Research PNCR network, originally funded by the SMA Foundation and currently by Cure SMA, and for trials testing novel treatments for SMA, including the clinical trials for Spinraza, nusinersen, and Zolgensma, onasemnogene abeparvovixio. He will pronounce that correctly, of course, approved by the FDA as the first two treatments for SMA, and for Risdiplam, approved as the third treatment. He receives frequent invitations to lecture at national and international meetings on topics related to his expertise in neuromuscular disorders and genetics. He has published over 280 original reports in peer-reviewed journals and over 80 chapters, reviews, and editorials. He is editor-in-chief of the second edition of Neuromuscular Disorders of Infancy, Childhood, and Adolescence, A Clinician's Approach, published by Elsevier in 2015, and served as the editor of the section on neuromuscular disorders in the 6th and 7th editions of Volpe's Neurology of the Newborn.
Thank you, Alex, for that very kind introduction. I hope everybody's warm today. I will spend the next maybe 50 minutes or so to present an overview of SMA, the current treatment landscape. And here are my financial disclosures, and also my research support. And I will start by saying that spinal muscular atrophy is a genetic term and has been used to define the chromosome 5q classic SMA, and also a number of non-5q SMAs, which are not very common. So today we'll focus on 5q classic SMA, which is a genetic condition characterized by generation and loss of motor neurons in the anterior horns of the spinal cord and brainstem, leading to muscular atrophy and weakness. 5q SMA is an autosomal recessive disorder caused by loss or mutation of the SMN1 gene and retention of the SMN2 gene. SMN1 and SMN2 genes encode the survival of motor neuron protein, and I'll refer to this protein as SMN protein from now on. SMA is caused by decreased levels rather than complete loss of the SMN protein, leading to selective dysfunction of motor neurons in the spinal cord and brainstem. And I say decreased levels because if the fetus has no SMN protein, it will never make it to the end of the pregnancy. So complete loss of the protein results in embryonic lethality. So going back to the time when SMA was described, it was really at 1891 when Guido Wertnig was an Austrian physician, described SMA, and shortly thereafter, a German physician named Johann Hoffmann described the same disease, which actually was an intermediate form of SMA, what we call now SMA type 2. And so, and it took about 100 years from 1891 to 1991 for the three-type classification to be established. So it took a long time, although Victor Dubovitch defined the three groups in 1967, and there was also an attempt by Byers and Banker. Randy Byers was the chairman of neurology at Children's in the 50s and 60s, and Betty Banker was a famous neuropathologist, pediatric neuropathologist, who described and both published a paper entitled Infantile Muscular Atrophy. And so they describe what we call now SMA type 1, but also they include intermediate forms. So the current classification was established in 1991, as I said, in one of the European Neuromuscular Center workshops led by Ted Mansart. Ted Mansart was the chairman of neurology at Tufts at that time. He had an interest in ALS and SMA, and they sat down and they decided to establish classification, which we used till now. Have the three main types: type 1, type 2, type 3. Type 1 was onset during the first 6 months of life. Type 2 onset between 6 and 18 months. And then we have type 3, 3A and 3B with onset before the age of 3 years and after the age of 3 years. But also have a SMA type 0, and this is a rare form. I haven't seen a case for a while with onset prenatally, and these kids are symptomatic at birth, and they died during the first 6 months. And then type 4 is the adult form of SMA, which is not very common. So talking about again about the classification, I think it is important to realize that the classification is based primarily on the best motor performance secondarily in the age at onset. With understanding we have a continuum of severity across the phenotypic spectrum with significant overlap between the different types. So we have SMA type 1, which are known as non-sitters because they never sit unsupported. Again, with onset of the first 6 months of life. And before the discovery of the disease-modifying treatments, 90% used to die by the age of 2 years. And then we have SMA type 2 intermediate variety, known as sitters because they never stand or walk but can sit at some time. And then we have SMA type 3. These are the walkers, the milder version, who are able to stand and walk at some time. I think it's important to understand that this classification is shifting because with these disease modifying treatments, we convert type 1 babies into type 2. In fact, they do survive, and some of the type 2s may manage to walk with the treatment, so they may come to type 3. This classification does not capture exactly what's happening what's going on at this time. So here's a baby with SMA type 1. You see that the typical frog leg position, the bell-shaped chest. They have diaphragmatic breathing, as you know, but they have that expressive, alert face. You can see, the father holding the little girl, very, very expressive face, which we don't see in other neuromuscular conditions, in myopathies in particular. And you can see on the right that there's a significant head log. When you try to lift them up vertically, they slip through your hands and so on. So typical appearance of a type 1 baby. And then we have the sitters, type 2, the boy and the girl on the left and the girl on the right sitting on her wheelchair. And the girl who is at the very right she has a SMA type 3. So SMA is one of the most common neuromuscular conditions in infants and children, and it used to be the most common fatal genetic disease in infants. And I don't want to target a lot of numbers, but the incidence is approximately thought between 1 in 6,000 and to 1 in 11,000 live births, which means that in Massachusetts we used to have 6 to 7 SMA births per year. And this is something, excuse me, that's going to change as time goes on. Excuse me. Before the discovery of a treatment and treatment of these newborns, as soon, shortly after they're diagnosed, about almost 60% was type 1, about 30% was SMA type 2, and about 15% was SMA type 3, with the adult form being less than 1%. So in the clinic, we used to see primarily SMA type 2 and type 3. We didn't have a lot of type 1s because they used to die by the age of 2 years. And but again, these numbers are changing with the introduction of disease-modifying treatments, which not only extend survival, but they also change the phenotype. Now, what is remarkable is the high carrier frequency. The average global carrier frequency is around 1 in 50 people, with a range between 1 in 40 to 1 in 60, and it's only second to cystic fibrosis. And the highest seems to be in whites, and the lowest seems to be in blacks. maybe because in blacks we have high incidence of what is known as the 2+0 scenario, which means that we have two SMN1 copies on one chromosome, and we have no SMN1 copy on the other chromosome. So when these people get tested, they appear as if they are not carriers when in fact they are. So here is I'm trying to see whether I can get the pointer here. Okay. So on the left you have a control, a section of the spinal cord. You see the motor neurons in the anterior horn, and on the right there's a specimen from a baby who died from SMA type 1, and there appears to be a paucity, as you see, of motor neurons in the anterior horn. And at higher magnification, you do see the motor neurons here, and not a lot of motor neurons, almost nothing in a baby who died from SMA. And some of the cells, they seem to seem to have this ballooning type of appearance with central chromatolysis, suggesting that we have neurodegeneration. So here we are in the beginning of 1990, and it was really at that time when Conrad Gilliam at Columbia University mapped all three types of SMA to chromosome 5q11.13, and 5 years later, the SMN genes were identified by Melke's group at the University of Paris. And that's when the excuse me, the molecular era of SMA started. Excuse me. So here we have chromosome 5, and as I said, it was mapped in this area of chromosome 5, and this is an area of inverted duplications about 500 kilobases. And it does contain the SMN1 gene on the telomeric side. And then humans, they have a second copy known as SMN2 on the centromeric side that differs from SMN1 by 5 nucleotides. Some people say 10. But one of them, a CD transition in exon 7 seems to be crucial. Because it inactivates an exonic splicing enhancer and simultaneously creates an exonic splicing silencer. This means that this particular copy of SMN, known as a backup copy, some people call it paralog or a pseudogene, produces primarily truncated protein known as SMN delta 7. So about 90% is truncated is not functional, and only 10% that's produced is full-length SMN protein, which is functional. So when humans lose both copies of SMN1, because most humans, they have a number of copies of SMN2, they survive and they develop SMA. So it is it is a genetic condition in which results in 95% of patients from a deletion of exon 7 and 8, or just 7 in both copies of this gene. And we talked about SMN2 that produces a 10% amount of full-length protein. So what's the reason we have 3 types of SMA? All 3 were mapped into the same area. The reason has to do with the number of SMN2 copies. About 80% of the babies with SMA type 1 have 1 or 2 copies of SMN2. About 70% they have 2 copies. Patients who have SMA type 2, the sitters, about 78% they have 3 copies of SMN2, and the walkers, 93% they have 3 or 4 copies of SMN2. Now, carriers, they have 1 copy of SMN1 on one chromosome, and they have 0 on the other, and it has between 0 and 3 copies of SMN2. So normal individuals, they have 2. Rarely they have 3 copies of SMN1 and 0 to 3 copies of SMN2. About 10 to 15% of normal people, they have 0 copies. In fact, myself, I have no SMN2. And there are some individuals out there who seem to be normal. When they've been examined, they seem to be fine. They don't have SMA. But they're examined because they happen to be members of an SMA family, and they found to have 0 copies of SMN1, but they have 5 copies of SMN2. So it does appear that that having 5 copies of SMN2 may rescue the phenotype, as they say in genetics. So we have an inverse relationship between SMN2 copy number and severity. The more copies of SMN2 you have, the milder the phenotype. But when we have a patient in the clinic, and with a report that said that the patient has 3 copies of SMN2, if you ignore the history in the physical exam, it's probably impossible to predict whether the child is going to have SMA type 1, type 2, or type 3, because you can see 3 copies can be detected in all 3 types. And what's the reason for that? It seems that not all SMN2 copies are equal, because SMN2 can be mutated, can be truncated or rearranged, and produce different amounts of SMN protein. In addition to that, there are individuals so it's a major phenotypic modifier, but it's not totally 100% predictive. But in conjunction with the physical exam and the history, I think it can be very, very helpful. And but there are also other phenotypic modifiers. For example, in 85-9 G to C substitution in exon 7 is a positive modifier because it creates an exon splicing enhancer, and thus it does increase the production of S7 protein. And then in intron 6, an A to G a transition also is a positive modifier. It makes the phenotype milder. And there are other situations where, like, the overexpression of proteins like plastin 3 and so on. So we talked about the SMN2 copy number and 3 types of SMA, and it doesn't happen now, but in the past we get a situation where they had a child would look like SMA. You send the DNA test to come back as a carrier, having like a deletion in one chromosome, and what seemed to be like a normal SMN on the other side. But if you sequence that second allele, you do find a small scale mutation, either a microdeletion, microduplication, missense mutation. So 5% of compound heterozygotes. It doesn't happen these days because the laboratories, they reflexively test the other allele. They do sequencing of the second allele, try to find a small mutation. But we have to remember the 5% are compound heterozygotes. So talking about the SMN protein, its function, it does play a critical role in small nuclear ribonucleoprotein biogenesis, and therefore is very important in spliceosome assembly, and therefore in pre-messenger RNA splicing. And also the SMN may play a role in transcription and other cellular processes such as axonal mRNA trafficking and transport in motor neurons, and perhaps in other processes like neuromuscular junction muscle. We do know that neuromuscular junction is not working very well in SMA. And it looks different, and also electrically behaves differently. But you can imagine that long like neurons with very long axons that have many targets in large muscles. They're very dependent on axonal mRNA transport, and that might be the reason why why we have the selective vulnerability of some of these motor neurons. It could also be that the SMN2 gene produces a very small amount of length protein in motor neurons. Maybe produces 2% instead of 10%, but that's something that needs to be proven. So coming to therapeutics, the goal of most drug trials has been to increase the production of full-length SMN protein from the backup SMN2 gene, or replace the SMN2 gene using gene therapy. So SMA has evolved a unique translational disease because the genetic defect is the same in all patients, and we have clear targets. We have SMN1 and also have SMN2. So it was around year 2000 when the NIH targeted SMA for treatment. It was thought to be like a low-hanging fruit because of the unique genetics, and also because there's also a mouse model that had been created at that time. And in 2004, the Pediatric Neuromuscular Clinical Research Network for SMA was created, which it's a consortium of researchers at 4 sites. It was a consortium at Columbia, led by Daryl DeVivo, at Boston Children's led by me, at Chapin in Philadelphia, led by Richard Finkel, and also we had University of Rochester was the data management and analysis site with Mike McDermott. Since then, Richard has moved to now Nemours, and then to St. Jude's. Stanford was also added with John Day. The support has come from the SMA Foundation for a number of years, and more recently by Cure SMA. So when we decided to create this network in 2004, the objectives were to study the natural history of SMA in a genetically and clinically well-defined cohort of SMA patients, to establish network infrastructure, to develop and validate outcome measures, and to conduct clinical trials for SMA and contribute to the development of an effective treatment within a decade or so. As you know, it's very hard to do clinical trials if you don't know the natural history of the disease. And from 2005 to 2010, we studied a large number of patients trying to define the natural history. And here the papers were published for type 1 and type 2 and type 3 SMA. There was also a NeuroNext study led by Stephen Kolb at Ohio State University, which also studied the natural history of SMA type 1, was published in the Annals of Neurology in 2017. We also focused on developing and validating outcome measures for SMA. For example, we developed an expanded version of the Hammersmith Functional Motor Scale for type 2 and type 3 patients, and also validated the Children's Hospital of Philadelphia Infant Test of Neuromuscular Disorders, known as CHOP-INTEND, which in combination with other outcome measures like the revised upper limb module, MFM32, were pivotal in the execution of clinical trials after 2011, 2012. So now we come to the therapeutic strategies for SMA. Research started as early as 2000 with different clinical trials studying ribitol, gabapentin for neuroprotection, and also phenylbutyrate, hydroxyurea valproic acid to amplify SMN protein production. And you can see from the F, all these trials failed. So since 2010, the therapeutics has focused primarily on a gene therapy, replacement of the SMN1 using AAV9 gene therapy, And also you use of antisense oligonucleotide technology to increase the inclusion of exon 7 in SMN2 messenger RNA, and also the oral medications for to enhance splicing, like this RG7916, and more recently anti-myostatin efforts. So talking about antisense oligonucleotides, there was an effort by Dr. Huyen in Andrea Krainer's laboratory at Cold Spring Harbor in New York, and in collaboration with Frank Bennett, to screen a number of oligonucleotides. And eventually they found one known as ASO 1027, or now known as nusinersen, which binds to an intronic splicing silencer site in exon 7. In fact, this one was discovered by Dr. Singh, the University of Massachusetts, which basically displaces a ribonuclear protein which stimulates exclusion of exon 7. So by inhibiting the inhibitor, we increase the inclusion of exon 7 to the splicing events, not only in vitro, but also when they administer this oligonucleotide using a microosmotic pump in mice. The inclusion of exon 7 went from 10% to as high as 90%. It lasted for 6 months. So at that point, it was felt they had basically a new drug to study to treat SMA. This antisense oligonucleotide has a 2O-methoxyethyl chemistry. It seemed to induce a phenotypic pathological benefit when given centrally in severe in mouse models, and seemed to have a long half-life, more than 6 months. And around that time, in 2012, there was a news feature in Nature Medicine called "In the Backup." The backup is the SMN2 gene, and it has this picture of this SMN delta 7 mouse, 9-day-old, untreated, and these are mice who die by 14, 17 days of life, develop necrosis of the ears and the paws and the tail. And after treatment, this is a 9-month-old SMA mouse who received antisense therapy. You see, no, it has survived. It looks pretty good. So we started the trials in humans, initially single intrathecal dose of what was known at that time as SMNRX, in 4 sites in the U.S. and Boston Children's, Columbia, University of Utah, and UT Southwestern Medical Center in Texas. There were no safety or tolerability issues with doses of 1, 3, 6, and 9 milligrams, and no serious adverse events. So then we moved to multiple doses studies using 3, 6, and 9 milligrams to evaluate the safety and tolerability of multiple intrathecal doses of this antisense oligonucleotide in medically stable patients to 15 years of age. And when some of the patients who received a single infusion in the spinal canal were studied long-term, it did appear as if the 9 milligram dose was having a benefit with a 3-point increase at day 29 and about 6-point increase 9 to 14 months later. And at that time, we tried to convince the sponsor to include a 12 milligram dose, and eventually they did that. And this is the one that was used in the pivotal trials, like the ENDEAR study, which was a phase 3 randomized 2-to-1 double-blind some procedure control study. It was a global study for many countries, which enrolled 120 patients under the age of 7 months with 2 copies of SMN2. using the 12 milligram dose, and with 4 induction loading doses and then maintenance dose every 4 months. And then we started seeing not only the patients who were surviving, the ones who received in fact, it was pretty obvious who had received the antisense. You can see they had better, strength was improved, and also they started acquiring milestones like sitting, which, for example, never happens in SMA type 1. Or standing with support. In fact, when the results of the DEER study were analyzed at the end, about 51% had what you call a motor milestone response. And I won't get into details of how that was defined, but basically these are the patients who acquired milestones compared to 0% in the sham control group. So it's a clear difference between the two groups. And again, this international study with different standards of care, but also the survival improved, the CHOP-INTEND score went up, and also the CMAP amplitude went up in this group of patients who received the medication. And then we moved on to a later onset a study with nusinersen versus sham control, which also was positive. And this is the trajectory of the nusinersen cohort, and this is the trajectory of the sham procedure control group. You can see there's clear difference separation between the two. The difference was only 4.9 points. I mean, statistically significant. The truth is that we're not seeing dramatic responses, but many of these patients had advanced disease. And based on the results of the ENDEAR study and some of the open label studies in the beginning, nusinersen was approved by FDA on December 23rd, 2016. As you probably know, you have to do a spinal tap, remove 5 ml of CSF, and inject an intrathecal bolus of 5 ml of 12 milligrams of antisense over a number of minutes. You have 4 loading doses, day 1, 15, 30, and 60, and then 1 dose every 4 months. And look at the cost here. 1 vial costs $125,000. And we also noticed that some of these patients were, oops, it doesn't seem to. This is a video. Let me change the pointer. So they seem to be doing well, and the best results were obtained in patients who started treatment within 13 weeks after the onset of the disease. This girl from New Hampshire was treated early because the first patient was supposed to be treated declined. So we brought her down pretty fast and she received treatment early. But not every child does as well as her. Some of these patients continue to have bulbar function issues. It's an invasive, lifelong treatment. And also, we understand the periphery is not treated. SMN protein is expressed everywhere. You have ubiquitous expression, and maybe it's needed also outside the spinal cord and brainstem. And not every child survives. We have patients who have died, had been receiving treatment for a while. So coming back to the same news feature, like article in Nature Medicine, I was interviewed along with a number of other colleagues, and I said maybe we'll be able to achieve cure if we intervene early. And the best evidence for the value of early intervention came from the nurture study, which also is a nursing study, where patients were treated during the first 6 weeks of life, but they had to be asymptomatic or pre-symptomatic. In this trajectory of the motor milestone response of the ENDEAR study, you can see that in the nurture study, the babies who had 3 copies of SMN2, they seem to progress almost essentially normally in their acquisition milestones. And even the 2-copy babies seem to be doing pretty well. In 4.8 years, all patients were alive and non-required permanent ventilation or tracheostomy. And at 4.8 years, 100% were sitting, 96% were walking with assistance, and 88% walked alone. And here's another video of a baby who was treated at 2 weeks of life.
Good job.
Very good head control. You can see and trachea control, crawling around.
Good job.
And then walking at 11 months. But look at the cost, $750,000 in the first year, and then $375,000 a year for the rest of his life. And now we come to gene therapy. And as you know, they tried to use adenovirus at the University of Pennsylvania in 1999 on a patient with urea cycle defect, by the name Jesse Gelsinger, and unfortunately he died from massive liver failure, liver necrosis. And then the adeno-associated virus came along, which thought to be non-pathogenic, has a good safety profile and long-term expression, and it's big enough to accommodate the human SMN cDNA. It has what they call a continuous promoter with a hybrid promoter with CMV enhancer and chicken beta actin promoter, and also there's inverted terminal repeats at the two ends. It does cross the blood-brain barrier. It does target motor neurons. It is thought to be non-integrated, although a small amount maybe integrates. And non-pathogenic, it does remain stable within the nucleus as an episome and has rapid onset of the effect and sustained SMN expression due to these inverted terminal repeats. So after uncoating gets into the nucleus and sits there as an episome, and you can see here in the nucleus, these are the inverted terminal repeats, and because of them, the synthesis of the second strand does not take a long time, and this is probably why we see efficacy and improvements even during the first month after the treatment. The first study was done at Ohio State by Jerry Mandel, Ohio State University, and these are three patients who received what we call the low dose, was about 6.7 times 10 to the 13th viral genomes per kilogram. And this is the high dose. You can see on this chopping tend graph, you can see that these 12 patients seem to be moving up pretty fast, most of them, except for this one here, suggesting that there was efficacy, but also when they look at their milestones, they seem to making a lot of progress with sitting, head control, crawling, pulling up to stand, or even walking independently. And it was approved by FDA in May 2019 with a warning about acute serious liver injury. So we try to mitigate this problem by treating with prednisone 24 hours before the infusion, and then for about 3 months after the treatment, and we follow the liver enzymes very, very closely. But the approval of those patients less than 2 years of age with SMA, with biallelic mutations in the SMN gene, without any type definition or weight limit. We also see thrombocytopenia during the first week of life, which is usually reversible and transient troponin I elevations, but we've never seen cardiomyopathy in some of these patients. We do worry a lot about thrombotic microangiopathy. There's about 9-10 cases that have been reported and about 5 deaths international from thrombotic microangiopathy. So we haven't had a case yet, but it can happen and it can be lethal. You cannot treat a patient unless the titer is less than 1/50 or just 1/50. So that's a limitation but it doesn't happen that frequently. And then we move to the oral SMN2 splicing modifier. We had this number in the beginning, and we discovered by a small biotech in New Jersey and seem to have a dramatic effect on extending the life expectancy of SMA delta 7 mice from 14 to 17 days to more than 150 days. So a study was started in Europe, and we're about to enroll our first patient, and we're told, and we received an email telling us to hold off because they found microcystic degeneration of the retina in non-human primates. So the study was discontinued. So they went back and they designed the molecule, and the new one that came out was RG7916, which also is splicing modifier of the SMN2 gene. And various studies were conducted and completed in the US, Europe, and elsewhere. This is given orally, and it does have a systemic distribution as expected, and it does bind to, known as risdiplam now, it does bind to two sites in the SMN2 pre-messenger RNA. And when we did the FireFit study for type 1 SMA, the results were very good, despite the fact some of these babies had advanced disease. The survival was 93% at 12 and 24 months of life. And also the primary endpoint of sitting without support was met. About 3% of the babies were sitting without support for 5 seconds, 60% at 24 months, and for 30 seconds, 17% at 12 months, 44% at 24 months. And you need to remember, without treatment, children with type 1 SMA are never able to sit without support. There are also other improvements that I would skip because we don't have a lot of time, but there was no evidence of eye toxicity that has been documented so far. A later onset study, Sunfist, was conducted, was also positive and FDA approved risdiplam in August 2020, but the cost is also high depending on the dose between 100,000 to 140,000 per year. And the approval was for patients 2 months of age and older, but different doses depending on the age and weight. And now we're good. So we had success with splice modification and gene replacement. Muscle activation has failed. We're using a fast-scale muscle troponin activator, but now we're conducting myostatin inhibition studies with 3 different sponsors, and hopefully we have some positive results. So here we are with 3 treatments approved between 2016 and 2020. And this is just to remind me, tell you that risdiplam was also approved for babies under the age of 2 months by FDA in 2022. So we have 3 treatments, but what determines efficacy? I think the major determinant is the number of surviving motor neurons in the spinal cord and brainstem. If the pool of surviving motor neurons is small, the therapy will not be very effective. And this is why time is motor neurons. And I used to show this slide until very recently. 48 states have implemented newborn screening for SMA in the United States. And 99% of the infants with SMA are diagnosed at birth, but it also happens in Japan, Australia, Europe, and elsewhere. And it was only Nevada and Hawaii that had not implemented newborn screening. And since January 8th, all 50 states currently screen for SMA, and 100% of newborns, babies born with SMA are diagnosed early in life. And this is a child who received gene therapy and at 3 weeks of life. And you see how well she's doing at 14 months of age. But look at the price, $2,150,000 for a single dose. So it does seem that these are the clinical trials for pre-symptomatic SMA, for nusinersen, a nurture study for onasemnogene parvovec, the sprint, and for risdiplam rainbow fish. In all 3, they seem to be effective, but we don't have head-to-head comparisons. In fact, the criteria that were used for let's say, for example, for CMAP were different in the 3 studies. So I don't think I can tell you which one is better. But it does appear that families have a preference for gene therapy because it's a single infusion. So we've been liking, I think we're doing well with 3 treatments at this point, but we still have some remaining major issues. Um, for example, although most 3 SMN2 copy babies do well, if we treat them early, there is a small percentage who seem to be symptomatic at birth, and those that will not do very well. I mean, that's rare. In fact, we haven't had a baby in our clinic with 3 copies who was symptomatic at birth, but it can happen. And now, 1 SMN copy babies are all symptomatic at birth, and the most of us believe that it's not a good idea to treat them. I don't think we're going to accomplish a lot, although there have been a few cases where we treated. We do treat the 2 SMN copy babies, but unfortunately, 40-50% of them are symptomatic at birth, suggesting that we have in utero onset. And the question is, shall we find a way to treat them in utero before they become symptomatic? So there's loss of motor neurons during fetal life, unfortunately, in the 2 copy babies and even the 3 copy babies. And then we have the 4 copy conundrum. These are babies who always look normal at birth. And the question, do you treat them or not? Our recommendation is to treat them because we don't have a perfect biomarker to pinpoint the exact time, the exact onset of neurodegeneration. So in the absence of a good biomarker, it doesn't pay to take a risk of losing, 40, 50, 60% of motor neurons just waiting. Because the physical exam and other measures are not really totally reliable. And then we have the symptomatic patients in our clinics. We still have a lot of problems despite the treatments, and we need to take care of them. And then there are questions regarding each one of the 3 interventions about durability, safety, and so on. And then we have the problem of cost. And all 3 treatments are expensive, and we feel that they've been overpriced. And then we have poor access to treatment in many parts of the world and even in the United States, and ethical issues, which we described, I think, pretty well in a paper was published in Annals of Neurology 2002 on the ethical perspectives on treatment options with SMA patients, for those who are interested in this area. So the cost, it seems to be a problem, and it will be hard to really tolerate this cost even in wealthy countries. And in Singapore, it probably has higher per capita income compared to the United States, but they have not been treating till recently. And one of their economists said that the treatment has to be cost effective. It must fit in the health budget of the country. So, so what's the solution to this? And Nigel Lane, who's a geneticist in Australia, has been a major advocate for preconception carrier screening, and this is something that has been recommended for SMA by the American College of Obstetrics and Gynecology, and also the American Society of Human Genetics, because, for example, Tay-Sachs was reduced by 90% in 10 years, and thalassemia went down by 50-80% in 3 years by the application of preconception carrier screening. So that's something. I mean, there are ethical issues they have to do with some of these reproductive technologies, but then, nevertheless, we should try to diminish the incidence of SMA as much as we can, and it seems that this is already happening because data from 2020, 2021 so the incidence of SMA was 1 in 18,000, let's say 19,000 live births in Massachusetts. And it was 1 in 28,000 live births in New York. But it does remain 1 in 11,000 in New South Wales in Australia and 1 in 7,000 in Germany. Again, the expected incidence I told you at the beginning is about 1 in 6,000 to 1 in 11,000 live births. And I did receive an email this morning for CureSMA telling me that the incidence of SMA in Massachusetts is now 1 in 22,000 live births. And when they looked at 30 states around the country, the combined incidence was 1 in 15,000, compared to 1 in 6,000 to 11,000. So the incidence is going down, and I think that's probably a way to deal with SMA, but that's just my opinion and some others' opinion. So that is the end of my talk. Thank you for your attention. I would like to acknowledge and thank many the funding agencies, sponsors, the team of research assistants, physical therapists, providers in our SMA clinic, research unit staff, as well as patients and families, and the funding sources. And this is what it takes to have an SMA clinic. You have involved a lot of people from different disciplines, like genetics, pulmonology, physical therapy, nutrition, orthopedics, and so on. And my thanks to the clinical coordinators that helped me over the years, and also our physical therapists. And at the end, the PNCR network PIs, and in particular, Dr. DeViva has been the heart and soul of the PNCR network since 2004, and the other colleagues in this network. Thank you for your attention. I'd be happy to take questions. Hello? I see. There is a question from Kevin Staley. Zolgensma is a pioneering gene therapy, and so may be the first to encounter long-term neural side effects such as persistence of SMA plasmid or effects of overexpression of SMA protein. What's the experience so far? Kevin, this is a very good question. In fact, there was a paper from Livia Pellegione's group from Colombia, where they treated mice with an AV9 SMN construct, and they did report SMN protein aggregates in motor neurons. And also, there appeared to be some form of regression in these mice in the area of strength and coordination. There are two human. We haven't seen any regression so far, but there are two human autopsy studies, and when they looked at the motor neurons, they could not find any SMN protein aggregates. The response that has been provided is that maybe this is just a mouse specific problem, but so far we haven't seen anything like this. And some of the Zolgensma patients have been followed for as long as how many years now? At least 8 years, 8 to 9 years. We haven't seen that. Hello? Hello? I'm still here.
Hi, Dr. Darras. Sounds like no more questions. I think we are fine today. Thank you so much.
You're very welcome. Thank you for the invitation.
Bye.
Appreciate it. You have a good day.
You too.
Bye-bye.